I've heard you use the term steroid stewardship. Could you explain to us what this means?
Steroid stewardship is akin really to antibiotic stewardship. And of course, we're all very familiar with how we need to be really mindful of how many antibiotics we prescribe, making sure that we're prescribing at the right time for the right patient because of resistance. Now, what we're talking about with steroid stewardship is similar in terms, yes, we need to make sure that we're prescribing at the right time for the right patient. And the reason being is that we know oral corticosteroids are very, very effective, and they treat and they manage, they're life-saving for acute exacerbations of asthma and potentially COPD as well. But unfortunately, we are all too well aware of the adverse side effects of oral steroids. And we are only talking oral steroids here, not inhaled. But oral steroids, we know, can lead on to diabetes, ischemic heart disease, weight gain, osteoporosis, and the list goes on and on and on. And we know that if patients have more than 1,000 milligrams of prednisolone, then you are leading on to more serious side effects. So the whole idea around steroid stewardship is around harm reduction, to think about, monitoring those patients who are on steroids to make sure that we have all the aspects of their care in place. So are the other medicines optimized? Are they adherent? Can they use the inhalers? Because all that may help reduce exacerbations. Are we referring people on to secondary, tertiary specialist respiratory centres to review these patients? So if patients have more than 2 or more oral steroids for asthma exacerbations, then we should be thinking about referring those patients through to secondary care. And of course, we have got biologics now that we can give these patients to prevent the need for oral steroids. And similar with COPD patients, we can't just keep giving COPD patients antibiotics and steroids every time. We need to stop and think, can we do anything more for this patient? And that's again where perhaps a referral to secondary care, or even if you've got integrated care services, that's ideal for them to perhaps to look more closely at that patient and help you to review them.
I can see that that's a useful approach. Now, what evidence is there of the impact of pharmacists working in respiratory medicine on, say, patient outcomes?
Yeah, there is some very good evidence actually of the role of pharmacists working in respiratory care in the UK, but internationally as well. And I know that they have different health systems, but it is worth looking at some of the services that are being conducted internationally. Obviously, we could do with more, and I would encourage any pharmacist working in respiratory to look at evaluating their role and to publish if we can, or to produce a poster, just so that we can collate more and more information of our role and impact working with patients and within the MDT. Probably just to flag some published sort of services. So Guy's and St Thomas's, their integrated care services working in respiratory. Lots of work going on there and have been published and have been recognised by NICE. BARTS as well, GP practice reviews for asthma and COPD. Those have also been sort of flagged as a sort of showcase as part of some of the NICE documentation as well. A community pharmacy service that we developed in Leicestershire called the Simple service, that's been again recognised by published in the Pharmaceutical Journal and other sort of publications. So there's pockets of very, very good practice which have been published.
And are there any policy statements or workforce plans to support the appointment of pharmacists in respiratory medicine?
I think for business cases, the other thing to look at is what support is there within national publications. So the British Thoracic Society, and I chair the BTS Pharmacist Specialist Advisory Group, we've just published an NHS workforce requirements publication, so setting out what we need for respiratory workforce in the future. And that's very much to have one specialist lead pharmacist for every trust. So that's a fully funded 250 pharmacists across for respiratory across the UK. Specialist comms pharmacists working with high cost therapies, and also 7 regional consultant pharmacists working in respiratory care. So that is a very useful document to say, this has been put by the British Thoracic Society.
And what about working in GP practices?
There's also another document called the NHS Accelerated Access Collaborative, and that's hosted by the Oxford AHSN. And that looks at the role of pharmacists in GP practices, very much focusing on adherence in asthma and referring on to severe asthma centres and what the pharmacists can do to support there. Finally, it's worth just looking at what the Federation of International Pharmacists are also doing. And there's publications coming out about the role of pharmacists working internationally in respiratory. And again, although that doesn't relate necessarily just to the UK, there will be reference to other services that have been published across the UK in that document as well.